Welcome to a really focused deep dive today. We're laser targeting non-alcoholic fatty liver disease, or NAFLD, to help you really get a grip on it for your revision.
Exactly. We've boiled down the essentials, aiming for high recall.
Think of it as your fast track. We'll cover what it is, causes, risks, how it develops, what else it might be.
Also, how common it is, how it presents, diagnosis, management, and, the longer-term picture.
Yeah, the whole thing. The goal is a clear, high-yield overview. We'll throw in memory tips, maybe some example questions too.
Sounds good. A mental framework, basically, to make it all stick. We'll
Yeah.
definitely highlight key links and potential exam angles.
Okay, let's dive in. Definition first, NAFLD. So, at its core, it's fat building up in the liver.
Right. But the crucial bit is, this happens in people drinking very little or no alcohol.
That N for non-alcoholic is the big clue, isn't it?
Absolutely. And it's not just one thing. It's a spectrum.
A spectrum. How so?
Well, you start with simple steatosis, that's just the fat being there, but it can progress
Progress to what?
to non-alcoholic steatohepatitis, NASH. Now that involves inflammation, maybe scarring, fibrosis, that's more serious.
Okay. So the H in NASH is for hepatitis, the inflammation part.
Exactly. Think inflammation. And it's actually incredibly common.
Right. You hear that a lot. Most common liver disease in the developed world.
Pretty much, yeah. And a big driver, as you expect, is the rise in obesity. The liver's kind of reflecting wider metabolic problems.
Makes sense. It's tied into metabolic syndrome then.
Very strongly. That mix of high blood pressure, high sugar, cholesterol issues, belly fat. NAFLD is often the liver sign of all that.
So like alcoholic hepatitis, but without the alcohol being the culprit.
Precisely. NASH looks like alcoholic hepatitis under the microscope, but the cause is different. So remember, NAFLD is the big umbrella term.
Covering both the simple fatty liver and the more concerning NASH. Got it.
Exactly.
Okay, let's move on to etiology. The causes. Sounds like it's not just one simple trigger.
You're right. It's usually a mix. Think genetics, metabolism, lifestyle. Sort of a perfect storm sometimes. They often call it a multi-hit thing.
Multi-hit. Okay, so what are the main players in that storm? What should we really focus on?
Well, those metabolic syndrome features are front and center. Insulin resistance is huge, often leading into type 2 diabetes.
And obesity itself.
Oh, definitely. Obesity and type 2 diabetes are massive factors. Interestingly, even if someone doesn't drink much now, past heavy drinking or even moderate amounts might make the liver more vulnerable.
Right. Anything else?
Rapid weight loss can trigger it sometimes, certain medications, some underlying metabolic disorders too. It's like a complex interplay.
Okay, that clarifies the causes. So who's most at risk then? Can we maybe group the risk factors to make them easier to recall?
Good idea. We can break them down. Let's call the first group primary risk factors. These are tightly linked to that metabolic picture.
So obesity, type 2 diabetes.
Exactly. Obesity, type 2 diabetes, insulin resistance, and the full metabolic syndrome picture. Also, maybe surprisingly, jejunal oil bypass surgery, an older type of weight loss surgery, can sometimes increase risk.
Okay, so primary factors are those core metabolic things. What about lifestyle? Things we can potentially change?
Right. Lifestyle factors. Being sedentary is a big one.
Yeah.
An unhealthy diet, obviously.
And you mentioned rapid weight loss. Seems counterintuitive.
It does, yeah. But very rapid weight loss, even starvation, can stress the liver and sometimes trigger NAFLD. Shows how sensitive the liver is to metabolic shifts.
Okay, lifestyle factors covered. Any others?
Yeah, there are a few other factors. Getting older increases risk, and there's definitely a genetic element. Some people are just genetically more prone.
Right. Genetics plays a part. Maybe an acronym helps. OMG, older age, metabolic issues, genetics.
Yeah, something like that could work. Broad categories to hang the details on.
Okay, so we know the what and the who. Let's get into the how. The pathophysiology. How does the fatty liver, the steatosis, actually develop? What's going wrong?
Okay, so the basic problem is fat, mostly triglycerides, building up inside the liver cells, the hepatocyte.
They just get overloaded with fat.
Essentially, yes. Imagine tiny fat droplets filling them up. It happens when there's an imbalance, more energy coming in than the body's using. That excess gets stored as fat, and the liver's a key site for that.
And what are the deeper mechanisms causing that fat buildup?
Several things can contribute. Mitochondrial damage, the cell's powerhouses can impair fat processing, though that's maybe more prominent in alcohol-related disease.
But still plays a role?
It can, yeah. But Crucially, insulin resistance is a major, major driver. When your body doesn't respond well to insulin, you get more fatty acids released from fat stores, and the liver itself starts making more fat.
Oh.
And then you can also have problems with the actual machinery, the receptors and enzymes that normally handle fats in the liver. So yeah, too much fat arriving and the liver struggling to process it properly.
Right. Now, before we go further, differentials are vital, aren't they? What else could look like an NAFLD? What needs ruling out?
Absolutely critical step. You need a mental checklist.
Mm-hmm.
Could it be alpha-1 antitrypsin deficiency? That's inherited.
Okay.
Autoimmune hepatitis, where the immune system attacks the liver. Celiac disease sometimes affects the liver too.
Right.
Cirrhosis from other causes, obviously like viral hepatitis. Drug-induced liver injury is important to consider.
So check the medication history carefully.
Definitely. Then there's hemochromatosis iron overload. Viral hepatitis itself, A, B, C, E, need to test for those.
Okay, quite a list already.
And thyroid problems, both overactive and underactive. Primary biliary cholangitis, primary sclerosing cholangitis, those affect the bile ducts. Even things like vitamin A toxicity, Wilson's disease, copper overload, and specific liver diseases of pregnancy.
Wow, okay. Like a thorough process of elimination then.
It has to be. You don't want to miss something else treatable.
Makes sense. Now, epidemiology, we said it's common, but how common? What are the numbers, particularly in the UK?
In the UK, estimates suggest around 20, maybe 30% of adults have NAFLD. It's huge.
1 in 4 or 5 people?
Roughly, yeah. And it's not just adults. In European kids, it's maybe 2.6 up to 10%. And NASH, the more serious form, is thought to affect around 5% in Europe.
Those are significant numbers. What about those high-risk groups we talked about?
Yeah, the figures shoot up there. Heavy alcohol users, anywhere from, say, 46 to 90% can have fatty liver alongside alcohol effects. And obese individuals could be up to 94%.
Almost everyone who's obese.
Wow. It really shows that metabolic link. And crucially, NAFLD is now a top reason for abnormal LFTs in developed nations. The rise in kids and teens is worrying too.
So given how common it is, how does it actually show up? What are the clinical features? Is it obvious?
Caution, no. In the early stages, most people have zero symptoms. It's silent.
Which makes it hard to pick up early.
Exactly. But as it progresses towards NASH, some people might start feeling, generally fatigued, maybe some vague discomfort up in the top right of their abdomen.
Under the ribs on the right.
Yeah. And sometimes the liver gets physically bigger, hepatomegaly, which might be felt on an examination. Raised liver enzymes on blood tests can be a clue, too.
And if it gets really advanced?
Well, then you can get into cirrhosis and liver failure territory with all the signs and symptoms that go with that jaundice, swelling, confusion in late stages.
So, summarizing the features.
Yeah.
Often nothing. Maybe hepatomegaly, ALT, often higher than AST.
Though not always, ALT can drop later. An ultrasound might show that bright liver appearance.
Increased echogenicity, yeah.
Some people do report fatigue or just feeling unwell, even with simple steatosis, but mostly it's found by chance, isn't it?
Yeah, incidentally on blood tests or scans done for something else entirely.
Exactly.
So investigations. If it's often silent, how do we find it and confirm it? What are the main tools?
Key tools are your liver function tests, LFTs, imaging, usually ultrasound first, and sometimes a liver biopsy.
The LFTs give clues, ultrasound shows the fat.
Right. Ultrasound often shows that bright fatty liver. MRI and CT can also be used, maybe more for tracking changes.
What about screening the general population? Should we be doing that?
That's a good question. NICE guidelines, the 2016 ones, actually say no routine screening for adults based on current evidence. It usually comes up when fatty liver is seen incidentally.
Okay, but if we suspect it, or find it incidentally, how do we assess how bad it is? Particularly the scarring, the fibrosis.
Right, that's key. There's a blood test called the Enhanced Liver Fibrosis, or ELF test, that specifically looks for markers of scarring.
And if ELF isn't available?
Then we have other non-invasive scores we can calculate, things like the FIB4 score or the NAFLD fibrosis score, NFS.
Calculated from standard blood tests and patient info.
Yeah, things like age, AST, ALT, platelet count, albumin, BMI. They give an estimate of fibrosis risk, combining these scores with a FibroScan.
That's the liver stiffness measurement.
Exactly. Measures how stiff the liver is, which relates to scarring. Using scores and FibroScan together is pretty good at predicting advanced fibrosis without needing a biopsy initially.
So high risk on those tests means see a specialist.
Definitely. They should see a liver specialist who might then consider a liver biopsy for a definitive look.
Going back to blood tests, what specifically do LFTs show?
While ALT is often the first to go up, showing liver cell injury, But importantly, it can fall later on, even if things are getting worse. And some people with NAFLD have totally normal LFTs.
So normal LFTs don't rule it out.
Not at all. We also run other bloods, remember, to rule out those differentials: lipids, glucose, full blood count, viral hepatitis screens, iron, copper studies, autoimmune markers.
That whole checklist we talked about.
Exactly.
And just to recap those non-invasive scores, nice likes for fibrosis.
Yeah, it's the NAFLD fibrosis score, NFS, the fibrosis 4, FIB4, and the ELF test. NFS and FIB4 can be done in primary care easily. ELF needs the lab to run the specific test.
Okay. And imaging ultrasound shows fat, but maybe not NASH or fibrosis as well.
Ultrasound is great for seeing the fat, that bright look, but it's limited in telling simple fat from NASH or grading fibrosis. CT and MRI give more detail, might be used to monitor, and FibroScan, as we said, assesses stiffness non-invasively. Very common in clinics now.
And the liver biopsy, still the gold standard.
It is, yes.
Yeah.
Gives a direct look at the tissue, confirms NAFLD, rules out other things, crucially tells you the degree of inflammation and fibrosis, helps predict prognosis, allows for grading and staging properly.
Right. So once we have the diagnosis, how do we manage NAFLD? What's the plan?
The absolute cornerstone, the main thing, is lifestyle change. Weight loss, regular exercise, healthy diet. That's number one.
Everything else hinges on that.
Pretty much. There's research into things like gastric banding, certain drugs that improve insulin sensitivity, but lifestyle is key.
So what are the specific goals of treatment?
Main goals are tackle the underlying causes. So weight loss is huge. Manage related conditions, blood pressure, diabetes, high lipids. Get those under control. That applies to both simple steatosis and NASH.
Are there any actual medications licensed for NASH in the UK right now?
Currently, no. No drugs specifically licensed just for NASH here. Now, U.S. guidelines sometimes mention vitamin E or pioglitazone for certain patients with biopsy-proven NASH.
But not standard practice here yet.
Not licensed for that specific indication here, no. So it really pushes the focus back onto lifestyle.
What specific lifestyle advice should we give patients then?
Okay, so gradual, sustainable weight loss. Aim for maybe 1 to 2 pounds a week. Crash dieting is usually not helpful.
Right. What about diet type?
There's good evidence for a Mediterranean-style diet. Lots of fruit, veg, whole grains, healthy fats like olive oil seems to help reduce liver fat.
And alcohol.
General advice is abstinence. Just avoid it. Regular exercise is vital too. Helps with weight, improves muscle, makes insulin work better.
You mentioned drug trials.
Yeah, ongoing trials looking at lipid-lowering drugs, insulin sensitizers, lots of research happening. Bariatric surgery is also an option for some severe obesity, plus an adage that can improve things significantly.
And specialist referral.
Yes, if there's suspicion of advanced fibrosis or cirrhosis based on those non-invasive tests or other factors, they need referral to a liver specialist for proper staging and prognosis assessment.
And follow-up is key, presumably.
Absolutely. Regular monitoring to check for progression, plus ongoing education and support for the patient. It's a long-term management process.
Okay, what about the long term? Prognosis, potential complications, what's the outlook?
It really hinges on whether there's inflammation and fibrosis. Simple fatty liver, just the fat, usually has a pretty good outlook if it stays that way.
But NANI's different.
Yes. NASH, especially with fibrosis, is the one that can progress. It can lead to cirrhosis over time, and having cirrhosis increases the risk of liver cancer, hepatocellular carcinoma.
So complications are cirrhosis, liver failure, liver cancer, mainly driven by NASH progression.
Exactly. NASH can lead down that path, and progression might be faster if someone has other liver issues or if their diabetes or cholesterol isn't well managed.
Which underlines the importance of managing those other conditions.
Absolutely. And it highlights why prevention is important, screening those at risk, education on lifestyle, managing metabolic health properly.
So the big takeaway message here seems to be, fatty liver sounds maybe mild, but it's definitely not always harmless.
That's it, exactly. We need to be proactive. Identify people at risk, screen appropriately, educate them about causes, management, prevention, why follow-up matters.
Right.
Anyone diagnosed with steatosis or steatohepatitis needs careful management, that education piece, and referral if needed. And, even slightly off LFTs and someone with risk factors warrant close watching.
Because the burden of NAFLD is growing, and early intervention really matters.
Precisely. It's a major public health issue now.
This has been incredibly useful, a really thorough deep dive into NAFLD. Hopefully that's given you a solid framework for revision.
Yeah, covering all the key areas from basics to management.
And for more resources to help with your revision, not just on this, but across the board, do check out passthemNAV.com.
And also freemasla.com for, well, free resources.
Great point. Thanks everyone for joining us on this deep dive.